in this work, moving from awareness of lead poisoning to action, and which is our theme this week at GHHI, and we're really pleased um, to have so many great partners through the state of New Jersey, just forcefully taking this issue on, from water to soil to housing to perinatal work. And you're going to hear from some of the best partners you can have in the country today, um, talking about this work and moving from this research that we will focus on to what are the actions that we're all taking together to ensure that not only that every child in New Jersey is safe from lead and has a lead-free future, but we know we have people from around the country joining us, and this will be up on our website and being shared with that. I have been around the country this week, and with more to come, heading out to California to continue the work on lead poisoning prevention. And we want to make sure that also, as we think about this, much is moving from federal onto the state and locals. And it will be so much around our ability to do code enforcement in housing, direct service programs like we have in New Jersey. We're using the funds from the DCA and the funds made available through the American Rescue Plan to ensure that every one of those dollars gets in to the homes of our kids in New Jersey, and that we pursue the existing and still bipartisan support in Congress and in Washington around lead being a priority. So it's been heartening to hear CDC, EPA, and HUD recommit on those matters. And I know as we move forward to a new administration in the state of New Jersey, we're looking at the priorities there. Our friends from Lead Free New Jersey and New Jersey Futures have done a nice job of compiling and putting forward questions to candidates, making sure that we know that this is such a critical issue. But we want to highlight the great work that's coming out of the state and out of Rutgers around what's happening in prenatal and newborns, and how far the really urgency is to go upstream to make sure that from the very point of inception and conception forward, that we're taking steps to eradicate exposures on all levels. And you're going to hear from some brilliant people. So if you go to the next slide, Catherine, our first panel is made up of researchers out of Rutgers, Dr. Damali Campbell, Dr. Ona Fofa, I hope I got that right, Dr. Harpreet Kaur, and our really good friend from the state Department of Health, Eric Binyet, and making sure that they are able to bring forth what we first presented at the Lead Free New Jersey convening in June, some really important data over a longitudinal study of the impact of lead and mercury on our young children, and some recommendations as we move forward there. There'll be a second panel today led by Natasha Tabakanoff from our team, and including Alex Feldman from Trenton Health Team, Laura Tillman from our partners at the Southern New Jersey Cooperative, and Dr. Kristen Pine from Monmouth Medical Center. And you're going to hear about what is happening in community to connect holistically answers on education, engagement, and root cause remediation. But let me just set the stage, if I can, a little bit as we go into this. Something that still keeps me, and I think most of our team, up every night is the 34 million families, or more than, that are waking up every day with facing significant lead-based paint hazards, and 22 million and more of those families have one or more significant paint hazards. And we know that the lowest income families in America, the 1.1 million families making $35,000 a year or less, facing these hazards, are the place that we need to go first and be able to address these issues, and for far less than we have invested in so many other things. For about the $250 billion of investment over a 10-year period by our country, we could really say that we are eradicating lead hazards in the home and exposures in a way that would save us over $50 billion a year in expenses that we spend on after the fact care for. And as we know, prevention is the only cure for lead poisoning, and something that we need to continue to think about. But low-income households have such a significantly higher impact, certainly because of the inability to have the funds to do essential maintenance practices, the investments, but also the history of redlining. And it is so critical that we really hone in on the 500,000 children in the United States today that carry a lead burden that will burden their future, not only in the classroom where there's a 700% greater likelihood of dropping out, but lower earnings over time, early mortality, cardiac issues, greater risk of hypertension. There's so many things that impact our community on a health basis, and also aggressive behavior that may lead to other problems in communities. We have the ability to change this future for our children, and I think that the commitment in the state of New Jersey by all of the organizations working on this are so important. Let's go to the next slide. So we got lots of things, right, that we can do, and I'm a big believer that we can make progress. We've seen states like Maryland reduce rates by 99.6%. Many other states getting close and coming forward on that. This week I've been in Pennsylvania, where there's big efforts to do that. We've got Delaware and Maryland all pushing in the Mid-Atlantic region on this issue. But we have to continue to keep the bipartisan nature federally, while we strengthen the capacity for governors, for mayors, for county executives, nonprofits across this country. So we have to continue to show the data, the outcomes, and the efforts that bear so much fruit. We have to be vigilant to ensure that the funding that HUD is putting out on the street, EPA's wanting to continue their leadership on lead, and continuing to make sure that the CDC lead office remains open. We have to be diligent and vigilant for these matters. And there are so many important partnerships that are happening around the country, where we have hospitals investing, Medicaid managed care investing. We even have utility funds in Detroit and others going toward home repair to remove lead hazards, and many programs around code enforcement that are increasingly moving forward. And we don't forget that we need to name our champions in these efforts. And certainly in New Jersey, the governor has been one. His term is soon going to be over, but there's so many at the nonprofit level, so many in the state agencies. You're going to hear from one today, but we need to name those champions, name the data, have broad engagement in all levels of communication, to not let the message just be about a week, about a day, but this awareness that we build. We have to keep pushing for action, for having those case studies that we can share with the media. I was on the phone today with Shelter Force, who's looking at articles around these health impacts on housing, it is important in every level, in every platform, that we continue to make the case and push forward. So let's go to the next slide there. So much to highlight about New Jersey and the $180 million that the governor put in through ARPA funds, which will run through the end of 26. We want to make sure every family has access to those funds that are being put out through DCA. And if you don't know who and what region of the state to contact, please contact us at GHHI at info@ghhi.org. We'll connect you to the network of grantees throughout the state who can help your families clean up the hazards in their homes. The expansion of policies, thank you to all the amazing advocates who have worked on pushing forward policies to ensure we register all rental properties, we inspect all rental properties, and we move beyond a visual. In New Jersey, we have to have clearance testing. We have to have stronger testing. A visual is a baseline, but what we know from research around through HUD studies and others is that visual alone will not get us to where we need to go. So we need to move forward on dust test clearance. We need to make sure that we're doing all of the strong risk assessment and clearance work that we can. We're grateful, really grateful to Tammy Murphy, who launched Nurture New Jersey in 2019, the establishment of the New Jersey Maternal and Infant Health Innovation Authority, the Family Connects New Jersey, which establishes a new standard for postpartum nurse visiting across the state, and the Maternal and Infant Health Innovation Center, which broke ground in Trenton, where we have our office in the summer of 2025. None of this happens without community action. And we've got these great strategic plans that we urge you to look at, and we will soon be producing a new strategic plan on lead with in partnership across the state with many nonprofits, local and state government players, as well as healthcare. So let's go to the next slide. So we also are looking at the fact that across New Jersey, we have state licensed maternal and child health consortiums that support lead screening and healthy homes programs. One of those great partners is the cooperative serving South Jersey, which launches the Protect, Prevent, Nurture Collaborative. You'll hear from Laura Tillman on this, I know, a little bit later. And this collaborative with family health initiatives and prematurity prevention initiatives to increase education of healthcare providers, parents, caregivers, all of us about the environmental exposures during pregnancy, and how the New Jersey legislature is now considering legislation, Senate Bill 3616, and that bill will mandate prenatal lead screening for certain pregnant persons statewide. And this is a critical and emerging trend because we know the impacts, and you're going to hear about them here in just a moment. So please get behind that and help us to get that passed. Let's go to the next slide. Well, this is I'm going to jump off and I'm going to turn this over, Eric, to you and the panel that we have coming forward. We welcome all of the good doctors that are going to share this great research. I know how impactful it was for me when you first presented this, and it has really shifted some of our own strategic thinking at GHHI. So thank you for bringing this to us today.
So thank you, Ruth Ann, for inviting us and for the very warm introduction. Can everybody see my screen properly here? Okay, we'll move on. It's good. I want to highlight that I am presenting on behalf of the entire team here. That includes everybody at Rutgers Health. It is through a really strong collaboration with them and a strong partnership that we're able to do all this work that we'll be sharing with you today. And I'm also thrilled to be sharing the panel with Doctors Campbell, Fofa, and Carr as well. Okay. All right, I'll start off by disclosing that I have no financial interest or other conflicts, and that the opinions expressed are my own, not necessarily those of NJ Health nor of our partners at Rutgers Health. We are the biomonitoring program here at the Department of Health. And for those who don't know, biomonitoring is the measurement of chemicals in people. There are many different sources: the food we eat, the water we drink, the air we breathe, clothes we wear. Pretty much everything is a source of exposure or potential one. Some chemicals are good for you, some are bad, and some are really, really bad. Today we'll be focusing on the lead and mercury ones. Why do biomonitoring in New Jersey? We are a state with a lot of risk. We are in the heart of the Northeast Transportation Corridor, so we have all the highways going through. We have waterways. We have a lot of railways as well. A large industry in terms of manufacturing. We do have oil refineries at various points throughout the state as well. In terms of hazardous sites, we have the highest concentration and number of Superfund sites in the country, and another 15,000 or so plus additional sites that the state is managing. Not only do we have all these internal risks, we have external ones as well. So mercury, for example, can travel thousands of miles in the air. So anything from wildfires out in California to coal plants in Pennsylvania add to our burden here. And we also have a very diverse population, and you'll hear about some of those risk factors very shortly. I'm not going to focus too long on this slide, but when it comes to health disparities, as Ruth Ann was saying, New Jersey has made a really long way when it comes to maternal mortality. We're currently 28th, which is middle of the pack. But when we started this work back in 2019, we were ranked 47th. So there's been a lot of effort through First Lady Murphy's efforts, as well as Department of Health and all of our partners to really improve these outcomes. That said, there is a very high risk for both Black maternal and infant mortality rates in New Jersey. We do have the biggest disparities. And when we look at the numbers of who are women of color, this really comes into play because when you look at Newark population, where we're doing this work, specifically University Hospital. So Newark is about 86% Black or Hispanic. University Hospital is closer to 98, 99%. So some really important numbers here. And with most public health services and medical services, those that have the highest need typically have the least access. So things to keep in mind as we look at some of the work that we're doing and why we're doing it. This work started as a collaboration between us and Johns Hopkins School of Public Health down in Baltimore. Dr. Wong runs the Boston Birth Cohort and has done so for over 20 years. It is a study that collects mother and baby samples at delivery and follows babies up to 21 years for those who get care at the facility. And we're able to look at all sorts of different outcomes. We did do some metals analyses for them and found some very interesting results. Those being that mothers transfer lead and mercury to the infants. In case of mercury, infants tend to have twice as high levels as the mother. These exposures can lead to negative outcomes at birth, so smaller head and stomach circumferences, younger gestational ages, smaller heights and weights, as well as throughout early childhood and even lifelong. So I'm not going to go through all of the diseases here and disorders, but suffice it to say that they happen at lower than the current health limits. So for lead, we know it's 3.5 micrograms per deciliter. When we started, it was 5. For mercury, we're using 5 micrograms per liter or parts per billion. We see these effects down around 1 for each, so about 10 times lower for mercury than we do for lead. One of the things that we noticed when we were doing this work was that we cannot go back in time and change effects. And so that led to the work that I'm going to talk about. First, I'm going to give a quick background on lead. Most people are very, very familiar with it, especially it being Lead Week. We're mostly familiar with it being in paints from the pre-80s as well as in water. Most exposure comes through inhalation, swallowing, eating, and drinking, though there are a lot of other risk factors that aren't typically thought of. The paint especially is, and the dust is important for children who have the mouthing behavior from crawling around. For adults, it can be anything from the use of cosmetics. It can be lead-containing pottery, the consumption of earth or soil from a parent's homeland to connect the baby to the homeland, as well as the use of Ayurvedic medicine. I really like this poster here from California. It does highlight that depending on where people come from, especially for foreign-born, the risk is going to be different. The products that they use is going to be different. And so knowing your population that you're working with, it really is important to understand what their individual risks are. Further, a lot of these, or some of these products are used by different parts of the world, but have a different name depending on where that's coming from. So if you're using the wrong terminology for the same product, then you're not going to be able to fully understand people's exposure. So mercury, we used to talk about as one chemical, but the more we look at it, the more we really have to look at it as four different ones. So methylmercury is the most toxic type. It is a type that's in fish and seafood. How this happens is I mentioned that mercury can travel in the air, it gets into the water. When it's in the water, the bacteria convert it to methylmercury. The fish are in it 24/7, they drink it in. It accumulates in their body, and then when small fish get eaten by medium fish, it absorbs all that. When medium fish get eaten by large fish, it absorbs all that burden. And then when we eat those fish, we absorb it. Ethyl mercury has been in the news lately. That's the thimerosal preservative. I want to highlight that we do not see it in our patient population. We do not see it in our statewide surveillance study, and that the CDC doesn't see it in its national surveillance study. So as far as this goes, there's not a significant risk from mercury from vaccines. Inorganic mercury is the next type. This is one that again has a lot of cultural ties to it. We mentioned Ayurvedic medicine for lead, also for mercury. Think items like cinnabar. Also in skin lightening products. There are multiple types of agents that lighten skin. Mercury is a very efficient one, and this is based on a history of colonialism, colorism, racism, and something that has to be very carefully addressed when dealing with populations that use these creams. And the last one is the one that most people are familiar with. That's the elemental form, the type that's in thermometers, light bulbs. Dental amalgam, silver fillings, not silver. They're actually more than half mercury. And then there's also some religious use of it. So we have some Afro-Caribbean religions in our state that use it, as well as in Hinduism, parad beads tend to have mercury in them as well. Okay. So when we're looking at exposure to these chemicals, there are a lot of bad things that can happen to people. I'm not going to run through the entire list again here, but I want to highlight these top 10. So if a mother comes in complaining about abdominal pain, about fatigue, about constipation, anemia, nausea, vomiting, and she is pregnant, the provider's not necessarily going to think, oh, well, you clearly are exposed to lead or mercury. It's just, we're going to be, oh, these are normal pregnancy symptoms. And so that's why it's very important to, look at the blood to test and see, rather than relying on symptoms alone. Second, there's also the communication. So we have mentioned eating earth earlier. If you ask somebody if they're eating dirt, they'll probably say no. If you say, it's common for in some cultures to eat earth to connect the baby to the homeland. Have you heard this is something you engage in? You're more likely to get a truthful answer. But in reality, that's not guaranteed. The other thing I want to highlight on this slide is that lead is the highest risk factor for preeclampsia, and something to definitely keep in mind when looking at high-risk populations. So as bad as it is for adults, lead is even more damaging to infants. As Ruth Ann pointed out, there were a lot of different effects that happen in children, breaking it down to neurological, with brain function and development, with just general development of different organs, as well as bones and muscles. Higher risk of preterm birth and even miscarriage. And then on the behavioral side, lower IQs, lower educational and career attainment, higher chance of living in a dangerous environment. And again, kind of perpetuating that for generations. So, and of course, we all know the studies about the higher risk of aggressive behavior tied to lead. Mercury, it's almost copy paste. Again, you throw in the neurological damage done in terms of brain development, nervous system. Kidney failure is especially associated with inorganic mercury, but also happens with methyl mercury. Blindness, deafness, microcephaly, same risk of preterm birth and death, as well as the behavioral issues. Okay. As I mentioned earlier, with the Boston study, these were collected at delivery. So, and in some cases were analyzed, 5, 10, 15 years after they were collected. So there was really nothing we could do. When we got the grant up here to do this work, we figured let's take this a step further. Let's translate this academic research into public health practice and medical practice. And so instead of collecting at delivery, we collected the mother's first prenatal visit. That allows us to get her educational materials right away, even before she gets her results. The prescription for micronutrients here, the ones that are highlighted, help mitigate the effect of lead and mercury in utero. So in one of the earlier slides, we saw that children are high risk of being overweight or obese if they're exposed to lead or mercury in utero. With adequate levels of folate, that risk goes away. But we also screen mothers and babies at delivery. So this allows us to get patients who did not receive prenatal care at the hospital or prenatal care at all. And it allows us to get a first reading for the baby as well. So we use cord blood for the babies. We have about a 98, 99% capture rate. For those that we missed, we use a heel stick. And importantly, we do the analyses here at the state, but the results go to the providers so they can provide support to the patients. We have a lot of resources, so generally there are centering and classes as well as educational materials. We strongly encourage the use of doulas. They do improve birth outcomes. There are also other local community organizations and healthy homes programs that provide prenatal resources to the patient population. If the mother or the baby are diagnosed as being exposed, they receive medical treatment. We have a diagnostic questionnaire that can help identify the source. I want to highlight that New Jersey Poison Control was part of the planning process here, and they've also provided support to both doctors and patients who have had high levels of lead and mercury exposure. In New Jersey, the jurisdiction for responding to child health cases, inspections, case management, things along those lines are at the local health department level. So we make sure that we report the results to them as well as to our COHS, which is our EPI for the state for the adult cases. Okay. We do follow guidelines for follow-up for lead for both mothers and babies. Generally, the more there is, the higher or the more frequently you test. Unfortunately, these do not exist for mercury. However, the providers have done a fantastic job of managing these cases. Okay, so I mentioned we started in 2019. We are up to about over 28,000 tests right now. We've found over 17,000 results that are above the health limit. Not counted or not shown here are another about 17,000 exposures. We've been able to provide a lot of educational materials to families, and most importantly, we've provided medical and environmental interventions to them as well. Now to what we're seeing. We chose Newark because of the well-documented lead concerns up there. We found that 2% of the mothers are above that 3.5 microgram per liter health limit. I did mention a range of 1 to 3.5 where some adverse health effects could occur, and 24% or about a quarter of our population for the mothers falls into that. What we weren't really expecting to see is mercury up there. We found about 4.5% of the mothers are above the health limit for mercury, another 45% are in the 1 to 5 range. These results are even more pronounced in the babies. 60% of babies, which is great news, have no detectable levels of lead. Typically, babies tend to have about 80% the levels of lead that the mothers have on the low end. However, when it gets on the high ends, you see the babies actually have about closer to 120%, if not higher, the amount of lead that their mother have. So about 1% of the babies are above the health limit for lead, but we still have about 12% of the population that's in a range where they could see some adverse health outcomes. On the mercury side, almost 10% of the babies are above that health limit, and another 50% are in a range where something adverse could happen due to that exposure. As far as mercury trends, we are seeing some good news. With the babies that are above the health limit, this is from 2019 to 2024, we do see a statistically significant downward trend. We also see kind of a change in terms of the amount of mercury or the types of mercury. So the dark blue is 100% methyl mercury, the most toxic type. The light blue is a mostly methyl mercury with some inorganic, and then the green is inorganic. As I mentioned, we don't see the ethyl mercury, the type that's associated with vaccines. And so what we're seeing here is less of the most toxic type by itself going to the babies, as well as less going to the babies overall. We do see that 2-to-1 ratio between mothers and babies when it comes to methyl mercury. When it's in the inorganic type here in green, it's more of a 1-to-1 ratio. That's because the placenta can absorb the inorganic type, but it cannot absorb the methyl mercury type. Okay, that was a population level look. In terms of case studies, this is the case for prenatal screening. Mother came in at 10 weeks, had high levels of mercury, 45 parts per billion here. We did speciation and it was 95% methyl mercury, confirming what she said in her survey about her eating larger fish. The providers had her switch to smaller fish, and you can see these numbers come down very quickly throughout pregnancy to where she's 3.5 at delivery. For a mom that's 45, we'd expect the baby to typically be around 90 when it comes to methyl mercury. Baby was born at 7.5, so it's still higher than 5, but it's much, much better than 90. So interventions do work extremely efficiently. The second case is a mother who did not receive prenatal care at all. She came in at 50 micrograms per deciliter. So if we're looking at parts per billion, that's 495 parts per billion. And the baby was born at 65.1. Very high levels. This mother did not have access to transportation, so Newark police had to bring her back to the hospital. The baby was chelated and taken care of. The levels went down. It did experience some delays, but the testing here was able to catch. This is a testing at delivery, was able to catch an exposure that would have not gone diagnosed until much later. The obstacles she faced are likely to pop up again when it comes to bringing that child to its wellness visits. And even if she does take it there, if they don't have point of care testing for lead there, she would have to get a script and go to LabCorp. Ideally be available during their open hours. So again, these challenges build up and up and up. And it's possible that this child would have not been tested at 1 and 2 years. So getting at delivery starts that process immediately and really improves the outcome. We put this slide in because lead is tricky. Lead gets stored in the bones. So even if you catch it early in pregnancy, and you can see these numbers coming down during the 3rd trimester, calcium comes out of bones to help with baby's bone growth. Along with that comes a lot of the mother's lifetime exposure to lead. And so it's possible that a mother has very low levels at the beginning of pregnancy, but by the end of it, there'll be a lot of lead coming out, depending on how big that burden is. So the great news is that we were able to cut it off and went down. And you see for the second baby here, even though those levels do go up, the second baby was born with less than half of what the first baby was born with. And the 4th study we're gonna share here is about a mother who had, again, two different babies. The first pregnancy went extremely well. You can see the baby had well below 3.5 for lead, and it was a nice healthy baby. She came in at even lower levels for a second one, but by the time she delivered, she was up to 36.3, and the baby was at 34.1. This baby had to be rushed for emergency heart surgery. She had moved 3 times during her pregnancy. During one of the moves, the plates that she was using broke, and she had to buy new ones that were poorly glazed ceramic ones. And every time she was eating, she was poisoning herself and her baby. And again, pretty much the only difference between the 2 pregnancies, a healthy baby and one that had to have emergency surgery, was that high lead exposure. Okay. We've done some retrospective chart reviews and found some interesting risk factors. Mothers that were above the health limits for either lead or mercury tended to be 7 years older than mothers that had no detectable levels of lead and mercury. One of the more significant findings was that foreign-born mothers tended to made up 75% of the women that were above the health limit, as opposed to only 20% of those that have no detectable levels. So while it is not the only risk factor, it is a very important one. And for people who have high refugee, high immigrant, high foreign-born populations that they're working with, definitely a factor to keep in mind, and making sure that these pregnant persons and their families get the tests they need. On the baby outcome side, we found a couple that were very interesting. Babies that were above the health limit tended to, or has a 75% higher chance of ending up in the NICU. They're also 6 times more likely to have an abnormal newborn screening hit. We don't have the exact diseases yet. We're still pulling out more data, and we're going to figure that out. Not shown here, but also significant were that they have lower APGAR scores at 1 and 5 minutes. So not only is this program able to provide interventions during pregnancy and get those levels down, the hospital does a fantastic job of getting kids into early interventions, and I'll probably let my co-panelists speak up about this a lot more later. But you see this child came in from high lead exposure at 4 months. The scores are all lagging behind the standards. After being in program for 1 year, you can see scores come up, and in some cases be at or exceed the standards. So it's important to show that not only can we lower exposures during pregnancy, improve that outcome, but then also we can provide support to these children once they're born and really help them catch up to children that haven't been exposed. Same is true for mercury. This slide shows low levels of mercury, right, between 5 and 7.5, and we saw improvements in patients for cognitive function, communication, and personal social behavior as well. Okay. Talking all about New Jersey, right? So Newark is I mentioned is similar to some other cities here, but overall we're a very diverse state. You can see we have a 50% white population, 10% Asian population. Women of childbearing age of Asian descent tend to have about 3 to 4 times higher risk of mercury exposure in general population. United States, we're looking through here, and we see very similar to Jersey. There's quite a bit of diversity. In terms of poverty, it's a risk factor. We all know that. And U.S. as a whole has about 12.5%. Foreign-born population, we're second to only California. That said, the United States has a lot of foreign-born population. And there are some cities as high as 74%. So if you're working in those cities with these populations, you really want to be looking at doing this testing. If you had old infrastructure, if you have poverty, pretty much do you really want to be thinking about this? I mentioned we have a statewide surveillance study. So for our moms in University Hospital, about 4.5% of them are above that health limit for mercury. Statewide, it's closer to 11 or 12%. So when you're looking at that 2-to-1 ratio, it's quite possible that right now about 20 and 25% of babies being born in our state are above that health limit. And that's not even counting that large percentage of babies that might be between that 1 to 5 range where adverse outcomes could be happening. So it's a very important thing to consider. Comparing it to other tests, so gestational diabetes is at 8% nationally, 3% for preeclampsia. We test for that. STIs, we test for that as well. Chlamydia is at 3% in New Jersey, 0.25 for gonorrhea, and 0.01 for syphilis. We test for that prenatally. These are newborn results. So congenital hypothyroidism is the most common at 1 to 1,200. Maple syrup urine is more rare, but 1 to 200,000. We test for that. We are not testing a standard of care across all babies for lead at 13.6%. That could be in a range that's dangerous, or 60% for mercury, where adverse health outcomes could be happening. So something that we're moving towards, but we're not quite there yet. As Ruth Ann mentioned, we have made a lot of progress nationally for lead, and we should definitely recognize that. It should be noted that some pockets of the populations haven't done as well as others. There are still cities where lead levels above 3.5 in children is above 20%, and we're testing compliance is down around 30%. But overall, we've done a lot of progress, and here's a chance for us to do some more with Mercury. I'm not going to go into the bill because Lauren's going to cover this in detail later. But I think that the important thing is that not only will the patients be tested, they'll be tested in that third trimester and make sure we get that lead coming out of the bones, and also families of children within the home that of any pregnant patient that is high will also get tested. So. Want to finish basically with, what can we do? We can understand these risks, right? They're pretty straightforward. We can improve our messaging to patient populations, to communities, to anybody who is an interested party here, and have constructive dialogue about different practices, because we saw a lot of this comes from cultural practices. So instead of eating earth, communicate that connection is already in the blood, that can be established that way. It doesn't have to be done through eating potentially contaminated soil. Educate everybody we can, all of our partners, anybody about these risks. Reduce demand and supply of harmful chemicals. And really start examining screening policies. So it really is two birds in one stone when it comes to lead and mercury. We can look at prenatal screening policies as well as neonatal newborn screening policies, but really think about women of childbearing age, and getting all the chemicals out with the caveat that lead gets stored in the bones, but prior to consumption rather than waiting to find out that the baby's being exposed. And lastly, children, right? We do screen for lead, and we see that we have a lot more mercury, and it's just as damaging, if not more. Then we should really look at that, and then focus on letting people know what resources are available to them to help. So I'm going to stop here by acknowledging a lot of people. I want to thank Ruth Ann and Green Healthy Homes again. I want to really thank my partners at Rutgers Medicine, Rutgers Health, Drs. Fofa, Campbell, and Carr, and the rest of the teams there, our internal teams. This type of work doesn't happen without a whole bunch of support. Please feel free to contact me with any questions. And at this point, I'll turn it back over to Ruth Ann. Thank you.
Well, thank you so much. And I want to just acknowledge your co-research team here from Rutgers who are on the phone and thank them. I see Dr. Campbell and others have joined. Really important here. Let's move. We're gonna move to the next panel. Let me ask you one question for the audience too. Hearing this information, learning from this, but just in general, we'd love to hear from you over the course of this, and as we come to the Q&A, what is the one action, if you're listening to this call, that you're going to take over the next year to raise further awareness and help us on our mission to eradicate the toxic legacy of lead? And with that, I'm going to turn it over to my dear friend and colleague, Natasha, who is just amazing and will lead the next panel. Thank you. And yes, copies will be shared on our website. Thank you.
Sure. So,
can I say just thank you, Eric, too, for amazing and great presentation. I didn't say that and I should have. Thank you.
Wonderful. I want to take a moment to move into a discussion of community and practitioner interventions with some of GHHI's fantastic partners and collaborators in New Jersey. So we are joined again, and I'll give them a chance to introduce themselves more fully in a second, but by Alex Feldman of Trenton Health Team, Lauren Tillman of the Cooperative, and Dr. Kristen Pine of Monmouth Health Center. So I want to start off by asking the panelists to introduce themselves, introduce their organizations and talk a little bit about the strategies they are using to expand maternal and infant health, including screening and primary prevention, such as environmental or medical interventions. Can I kick it to Alex to start us off?
Sure. Thank you, Natasha. And thank you everyone for having me here today. So my name is Alex Fellman. I am the Director of Community Development at Trenton Health Team. We are a nonprofit organization based in Trenton. We've been here for almost 20 years. We are dedicated to the health and well-being of Trenton residents, and we do that through three primary ways. We are deeply connected to our community. We're working with community members one-on-one every day through our community care team, which is made up of community health workers, navigators, folks who are from the communities we serve, who are helping to educate residents and help them navigate not just health issues, but really anything that's going on in their lives. We are also a convener and a backbone organization. So we bring partners together to work on specific issues, maternal and infant health being a big one. We've been very active in the maternal and infant health space for a long time. And I'll talk more about that in a minute. But we've also got working groups around food insecurity, around community health workers and best practices there. We led a collaborative that was awarded the Robert Wood Johnson Culture of Health Prize this year. So very proud of our partners in Trenton. All of that work, both the community level and our sort of convening work, is driven by data. And that's sort of our big third pillar. We've got a dedicated data and analytics team. We manage a community health information exchange that sees Medicaid claims data from a 6-county region in New Jersey. We're able to use that data and other sources to drive decision-making, both for ourselves and for our partners. So in the maternal and infant health space, as I mentioned, we've been active in this space for a long time. The Family Connects program that was mentioned kind of at the top of the presentation, we actually piloted the first Family Connects program in New Jersey, and that's now rolling out across the state. We are also one of the 3 anchor tenants for the Maternal and Infant Health Innovation Center. You'll also, the other 2 partners being Capital Health, who's the clinical partner, and a collaborative of higher education institutions led by Rutgers. Our job there is to ensure that every client coming into the Innovation Center gets connected with a community health worker and has a seamless experience between both their clinical and social supports. So one of the things that we're working on now is a pilot program with Capital Health to ensure that those systems are in place. And, we're kind of practicing with Capital Health pregnant patients now to ensure that we have the system in place to refer them appropriately, get them the resources that they need, and kind of work with them throughout their pregnancy and beyond. The other big piece that we are hoping to work on soon is an 1115 waiver. For those of you who are not familiar with what I just said, so 1115 waiver is a process by which the state Medicaid program, in this case NJ Family Care, can go to CMS or the federal Medicaid program and say, we want to try something. We want to do something different. So this is a demonstration. It's another pilot program. So we've teamed up with Horizon New Jersey Healthcare and ISLES to create a home visiting program pairing community health workers with pregnant patients. So as soon as they're coming in for their first prenatal visit, we're also matching them with a community health worker who's going to give them a referral for a healthy home assessment, make sure that the home is safe before baby comes home, and ensures that the pregnant patient and anyone else in the household, including any existing children, and particularly those who are under 6, are tested for lead. So we're testing this idea that a prenatal intervention can reduce the risk of lead to new baby who's coming into the home, and also improve screening rates as a method of getting more folks tested early on. So I'll stop there. We'll talk more about what we're learning from those things in a minute. But thanks again for having me, and I'll pass it to Natasha, and you tell us where we go next.
That's wonderful. Can we hear from Lauren and then Dr. Pine?
Yes, good afternoon, everyone. My name is Lauren Tillman. I am the Associate Director of Public Health Programs at the Cooperative and Family Health Initiatives. I think I play a delightfully unique role within this realm just for bridging. Two programs that I do oversee is our Prematurity Prevention Initiative program, which is actually a statewide program. And then I oversee our Lead in Healthy Homes program, which is specific to South Jersey because we do run the Southern New Jersey Coalition for childhood lead poisoning prevention. But having these two programs kind of marry together allows us to extend our reach throughout the entire state of New Jersey to spearhead this campaign called Protect, Prevent, Nurture, which is a campaign that was kind of birthed. Thank you for sharing, Catherine. A campaign that was birthed from the information of the lead law A4848, and also known now as it's on the Senate level as 3616. So with the conversations of that, and then our partners at Isles with Elise Pivnik, she's been a huge champion with this particular bill, which will require physicians to test pregnant people first trimester and third trimester if they show up any concerns. So it's not universal screening. I mean, we would hope for that, right? But if there are concerns brought up, then and they are flagged, then they will be tested. So this would require physicians to test the patients for lead screening, which of course we know that would definitely assist with the prevention later on. So Protect, Prevent, Nurture is a campaign that was created to, again, extend the reach throughout the entire state of New Jersey. And a lot of our New Jersey partners are involved in this campaign, including Eric, who just presented that wonderful presentation, as well as Dr. Campbell, and again, Isles, and then all the three coalition leaders are also involved in this campaign in New Jersey. But it is to spread the awareness of the potential of this law, and also just the awareness of pregnancy and lead exposure. So that's what we wanted to highlight on and focus on now. We have resources for both community members as well as professional, like physicians. So we actually created two subcommittees. One subcommittee focuses specifically on community education. So educating families, educating any community member, educating the parents directly about the effects of lead poisoning and pregnancy and that connection. And then we also have resources specifically for professionals about screening pregnant people and the importance and the why that is necessary. So we are still building more and more resources for each group. And the main point of kind of creating this is to make sure that all messages specifically about pregnancy and lead is spread cohesively throughout the entire state of New Jersey. So we don't want, community members or patients learning one thing or saying or hearing one thing, and then the provider is just in the dark and not aware. So we just want to make sure that all the information that we do provide is cohesive through an entire state of New Jersey. And yeah, so that's the role that we play, specific to, of course, the great presentation that Eric presented, and in our actionable steps for assisting with the fight against lead in pregnancy. Thank you.
So I'm Kristen Pine. I'm a general pediatrician and hospitalist at Monmouth Medical Center and the Monmouth Family Health Center in Long Branch, New Jersey. So I'm the pediatric residency program director there. So I've been specifically involved in education on lead exposure and prevention, directed more at trainees. I also am involved in advocacy. I co-lead the New Jersey Pediatric Residency Advocacy Collaborative, which provides advocacy education to all of the residency programs in New Jersey. So one of the topics we've been passionate about is, having trainees have more exposure and understanding of kind of the risk factors and other factors associated with lead exposure. And again, the public health impact on communities that lead exposure can have. We actually did do a recent presentation through NJ-PROC for all of the pediatric residents, which was great. I'm also involved in community health, and so have done some community outreach events for community members on lead exposure. And then most recently, I was also involved in a quality improvement project, both for some of our pediatric trainees, as well as for other pediatricians in New Jersey through the New Jersey chapter of the American Academy of Pediatrics. And so this study was aimed at pediatric practices, improving our screening and intervention for lead exposure and providing education to families on how they can prevent lead exposure. So if there's any pediatricians in the audience, or a pediatrician who might be interested in improving processes for lead screening and interventions in their outpatient clinic, would definitely reach out to NJAP or me to get involved in that, because it is obviously very important topic, and something that we really want to prevent, because the best treatment for lead exposure is preventing it in the first place. Thanks.
So an amazing set of partnerships here and building forward toward the legislative agendas. So we're going to be in touch with all of the groups that are here today. We have over 120 participants, but looking at how do we build this advocacy. I noticed here, Catherine and everyone on the screen, Eric Ritter put up a post about giving lead test kits away and equipping prenatal care providers, and making sure we can advance this work. I don't know if the AAP is also supporting that, how we're looking at doing that. I know that the EPA Region 3 has given lead care test kits and systems to GHHI, and we've been able to help counties throughout the state of Maryland and other places in Region 3 to expand testing, whether it's in rural communities or urban communities. And even in New Jersey, we have rural communities that are often overlooked, or small townships, or harder to reach places. And so I'm not sure what everybody is doing about that broader outreach. I know for the Trenton Health group, you've got a very specific footprint, but I think you've expanded beyond Trenton a little bit, right? There's so many best practices here. Is there advice that you would give community advocates who are working with parents who are listening today? Anything about their own engagement, something very concrete, obviously supporting the adoption of the bill, but other things that you all would give advice to? Lauren, can I start with you on that?
Yeah, absolutely.
Because I knew I'd just put you right on the spot. I jumped in, this was unscripted, but I just had that listening to you all about how do we turn this from awareness to action?
Yeah, no, absolutely. I will say, one, if a parent is interested in getting more involved, each region of the state has, again, a coalition that is open to everyone. So they could even join the coalition if they would like, within their region, and connect with the professionals there. I will also say, even the campaign that we're doing, we don't shy from, because we need those experiences, right? So we don't shy from advocacy work from lived experience as well. So I would say an easy thing, or I think would be kind of fairly easy, would be taking advantage of the different consortia within the within the state of New Jersey. They're pretty out there. You can just go to their sites and connect with someone. But I would say to start could be to join the coalitions and to join these different subcommittees that are doing the work.
It's great. Advice from Alex or Kristen or Natasha on anything else?
I mean, I think just in terms of being aware of things that are currently available in the community and where you can get blood testing, obviously talking to the pediatrician. WIC does perform blood testing as well, so that's another resource for where parents can go. I think most counties have a place that they can get home inspection too, so if they're concerned about lead exposure, reaching out to those. For Monmouth and Ocean County, it's the Community Resource Center. I can find like the contact information and put in the chat as well, but other counties have similar resources.
Yeah, I think I'd echo that. Certainly in New Jersey, we're lucky to have the resources of like the regional consortia and a lot of infrastructure built around that. I think if you are outside of New Jersey, which I think a lot of our
We got a
attendees
lot
here
of folks
today
here.
are, I would look for those community level organizations, particularly if you have another organization in your area that has a community health worker or someone similar. We find, part of the reasons why we're so invested in that model is that, we're able to create real connections with people on a level that is approachable, and really meets people where they are. So it can be intimidating to, go to your county health office or to go to your pediatrician even. So finding those organizations that have more community level response, even if it's not an organized coalition, there may be partners out there who can help you get the resources that you need at a more grassroots kind of neighbor to neighbor level.
Yeah, I mean, the young parents, people thinking about having babies, folks with young kids, all have to think about not only the chipping paint in their house and the water and the soil, but what's in their spices. There were more alerts that came out on more cinnamon being coming up with high lead levels. And in many states. I was looking at the data recently. It was paint and then spices and food sources and those things related to that, and then water. Water is critically important too, but where the sanitarians and inspections. But the other is people need to get connected to the idea of how do you contact code enforcement around things that may help. If you are able to get code enforcement to work with you on home repair or some issue around that, they may well end up getting some good lead prevention going as well. And we got some great things being shared here. Catherine and Natasha, I'm going to turn it back over to you for any further questions or close out. I just think the panel was terrific and great partners, I have to say. So it's good to have smart people that are good humans. Dr. Campbell's come on as well, and just encourage people to ask questions here as we move to actions we can take.
Thanks, Ruth Ann. Yeah, we have a good amount of time for questions for all of our panelists. And I want to thank everyone already for what you have shared and appreciate the feedback and questions that we've gotten from our audience members. So Natasha, maybe I can ask a couple of things of our Rutgers research team, and then we can follow up with a couple more on our community engagement partnerships. So I think we can start off by asking our Rutgers team, we'd love to hear more about how this project and the research work that you've done has changed maternal and infant health services within the Rutgers system, and if you're aware of that impacting other activities in hospital systems related to screening for maternal and infant patients.
Maybe I would take it on first. My name is Anna Fofa. I'm a pediatrician and neonatologist and the chair of the Department of Pediatrics. So the program in the 6 years that we've been involved with Eric has really strengthened our partnership and collaboration internally. When you have a project like this that cuts across departments, it's not always easy to have people comply. And what I'm most proud of from the work we've done is the high compliance rate from intake in prenatal care to evaluating and assessing these mothers and newborn babies at the delivery. So the compliance with the testing using cord blood. And then as we evolve to the follow-up on the outpatient side, partnering with our early intervention team, our WIC program to help ensure that the mothers not only receive the necessary information, but the follow-up. And then the last aspect of it is what happens in the community. So the Department of Health locally, for example, in Newark, there is an abatement program. So it's not just that we screen and test and detect, but we follow up in the community. And then the last aspect is what is happening within the professional groups. Say, for example, in neonatology, each time we present this work, first at the state level in the neonatal program, it was well recognized and certified by the professional colleagues. And then we took it to the national level, and again, the recognition has been well accepted. And so I hope that whatever comes out of this will continue to persevere on our end and hopefully extend it broadly.
Thank you so much, Dr. Fofa. You actually answered a couple of my questions with that answer, and highlighting the connectivity there, I think, is so important. Very much appreciated. Dr. Campbell or Dr. Kaur, do you want to echo or add to any of that? I think really our primary questions for follow-up with you all are a lot of the themes that Dr. Fofa highlighted. The work that's happening within the hospital system, the supporting actions from the health department, WIC, and other partnerships in community, as well as the community-based services and connectivity to housing-related programs. So anything else that you're seeing in terms of partnerships that you want to lift up?
Rosa, please come to the front desk.
That's
I'm at work. I would just say, one thing that I think, I would like to highlight is really more of a partnership with the patient, and really because, there's a lot of coordination professionally that goes on. But as was mentioned, it's, you really have to get to know patients and have a certain safety in when they're talking to you and knowing what the right questions to ask regarding some of the skincare products, in terms of some of the, eating habits and things like that. And so I think overall, it just allows us to provide a more comprehensive education once we understand more about, where this lead and mercury is coming from. And I think just in, the general public, there's more conversations about environmental toxicity and environmental hazards. So I'm finding that patients are, having more questions about these things. And actually, it's interesting because, a couple of weeks ago, a patient was like, I want to find out more about my lead level. And I said, well, you were tested at the beginning of the pregnancy, but because it was normal, nobody, so that provided a level of comfort for her, because now, we do all these tests, and then, patient comes back and in one fell swoop, we say, yeah, everything is normal. But what's everything, right? So when I went over it with her and I showed her her lead level was normal, was low, very low, and her mercury level was very low, that provided a level of comfort. And I think sometimes we underestimate the level of comfort when the patient gets normal results that can provide, because they're living in a very stressful environment when they're hearing all these things in the news and on the radio about, your community, and this is bad, and, you have higher risk. So just being able to provide that, this part is good, you're okay, can be very reassuring, and it can allow us to educate ourselves, about get more in tune with some of our patients and practices. Thank you.
Thank you, Dr. Campbell. And I think a lot of us
Yeah.
working on the environmental health service side of things feel the same way about the comfort we can bring when So appreciate you highlighting that.
Good afternoon, everyone. Yeah, I was having some technical difficulties to unmute myself. Sorry about that. So I think it was a great collaboration from the time, if we go back and look for all these 5-6 years that we have done this work together. And I want to say, I think we as a team at Rutgers have learned a lot from Department of Health, from Poison Control. I think during this journey, we did recognize the problems that are there in the community, how we should take care of this problem. It is, as Dr. Campbell was saying, it's talking and educating the families, but besides that, it is first educating ourselves also and our team also, because we were learning during this course, what are the risk factors, what should we educate the parents. Every time we look into these materials, like for our questionnaires, for our education material, we find out something new and we add into it, and then we ask those questions to the parents. So it's not only educating the population, it was also a journey of educating ourselves and making ourselves more aware. So I think it would be nice to, as what you are doing is, bring it to the world, right? I think it is more important that this information that we have gained now, we bring it in front of the world and tell them this is what we are finding out. And I think it's nice to be aware of the problems that we see, so that if it is there in their population, then they can address this issue too. So I think the collaboration has took us a long way along, and there's still a lot to learn from here. And thank you for having us here today.
We really appreciate you all taking the time to join this conversation.
Thank you.
Thank you. So I know I'll look at our chat with questions. We're getting some in from the audience. While I'm doing that, Natasha, do you mind asking our other panelists some of our follow-ups?
Yeah.
If I may, sorry.
Please go
guys.
ahead, Dr. Fofa.
If I may say to Dr. Pine, because she mentioned her presentation and the work with the residents in the state level. Just last week, before the I think they held a meeting last Monday. The resident who was rotating with me did say, "Oh, I'm going to NJ Prague for a presentation," and I said, "Oh, are you familiar with the work we're doing at University Hospital?" So she came back and was so excited about the opportunity to participate. So keep it up, Dr. Pine.
Thank you. Yes, it was a great presentation. So
That's great. I want to head back over to our community panel and kind of draw out something from what Dr. Campbell said. I'm wondering, when it's not in a medical context, when it's more in a community context, what are the messages or kind of information and education that resonates with parents or with expectant parents, while keeping the information you're providing evidence-based and not scaremongering about environmental toxins?
I mean, I think from our standpoint, just keeping the advice very practical, giving solutions to how to prevent their exposure. Because I think there are, with this particularly, there are, for a lot of things, there are very, practical interventions that we can give to families. Obviously talking about, we have patients whose parents work in construction in the community, making sure that they change their clothes, don't bring their shoes in the home. We always let them know making sure that children who may be outside in contaminated soil aren't putting the soil into their mouths, watching for those things, running cold water through the pipes before drinking water. And so I think, parents might not be aware of these things, so making them aware is helpful. And also, other exposures, like we were talking about the spices, a lot of our patients that we see are immigrants. So talking about, ceramics, things like that could be potentially contaminated with lead. So, everything that all the advice that we give has like a practical solution and prevention tactic.
And I think when it comes to mercury, most of the pregnant women are just aware that fish is good during your pregnancy. So just making them aware of the right fish and the amount is which we give during our educational material. So I think that is really very helpful to just educate them, which we do during the first visit. And of course, lead you already mentioned.
Lauren, was there something you want to add as well?
I was just going to echo it. And Dr. Carr just added on to that as well. One, literacy is very important. So making sure that the information that is provided is understood, no matter the reading level. So I think that's very important, making sure that materials that are not hard to read, not too wordy when it comes to community engagement, and also providing different resources and tips and tricks to like kind of have them feel more empowered. Because sometimes, if you're talking about lead, it feels kind of defeating to hear like you can't do much, but giving them information that that helps them understand that they do have some power to take, and providing certain things like healthy home bags that gives cleaning supplies and different tips that a person can take home with them. So just want to highlight and reiterate the importance of like education and meeting people where they are.
And if I could just chime in, I think, the messenger also matters, right? So if I say something to somebody about, reducing exposure, it's going to be different than if Dr. Campbell says it, and it's going to be different if a community peer says it, right? But we're all saying the same thing and amplifying the message. We found that some of our most effective recruitment as well as communication has come from educating community doulas, community health workers, community peers that bring that message as a trusted source to the community, and can talk about some of these cultural practices with far more understanding and experience than somebody who's not from the community. So really tapping in at the very grassroots local level.
Thank you, Eric, for the plug for that sort of grassroots level. I just want to add on to actually what Lauren was saying about literacy. I think that is an excellent point. The other piece I'd add to that is, we talk a lot about translating materials into multiple languages. Literacy in those languages is important too. So don't just throw it into Google Translate and expect that it's going to be understood. Like, build a relationship with your local translation service and make sure that they're translating things to a level that's appropriate for your population.
Something I'm not sure I've heard is based on our experience here, and it comes from the issues about immigrant population. And I don't want to get in the context of who's an immigrant, but what the point is really when you look at the unregulated business when it comes to food or some of the imported items, the skin lightening creams and all of those things. So the local bodegas, for example, and fish being part of that, it might be something we in the community would need to focus on, because sometimes, some skin lightening creams, for example, those that are made in the US that come through the regular proper channel, we know there's no mercury in them, but those that are imported as part of the business. So how much of education we should be in the community level partnering with our commercial industries is what I hope we can also do, and ensure that as we educate ourselves, educate the community, we also need to educate the businesses.
Yeah, thank you. I think we've gotten, actually, so as Ruth Ann framed at the very beginning, I think one of the impetuses for this like in-depth profile of prenatal screening for heavy metals in New Jersey was to demonstrate the local and state action level that we have the power to implement right now. And I think we heard about 100 local interventions that you all are working on across the state. Maybe before we move to audience Q&A, if anyone has any final thoughts on sort of the role or power of local and state entities in this moment, we could benefit from hearing those. Or we can let that cook for a little bit and move to an audience Q&A.
Yeah, sounds good, Natasha. Thank you. I do know we've got a few sort of interacting questions here in the chat, and appreciate people sharing those. One that Eric Bean wanted to reply to is the questions about other hospitals replicating some of the work that Rutgers is doing. So Eric, do you want to share a little bit more about that?
Yeah, so when we started this, we were looking for partners, and we found some very eager and capable partners up at University Hospital through Rutgers Health. And at the time, there was no precedent for this. This was the first of its kind proposed study that was going to be taken on. The data that we generated together was so compelling that other hospitals are extremely interested in it right now. I mean, and you saw it earlier, it speaks for itself. We have all the legal documents and everything in place for New Brunswick. We should be starting there by the end of this year. There's also, we're in the final stages of the legal documents to bring this testing down to Trenton. We mentioned NJMIA as a health center opening up in Trenton. That's another opportunity for us to bring that there, and then the legislation, which is going to really expand this, and getting out there, getting knowledge to providers, and showing that not only, and I think this is probably the most important thing that came out of the work that Rutgers Health did, was that not only are we able to test it, but we're able to do something about it and get those numbers down, right? We see those numbers in individual pregnancies come down. We also see those levels over time come down, as we saw in those babies and those mercury levels. So, and kind of going back to the what can state levels do? We did all this by applying for grants, and starting with pilot programs to generate the data and show the need. That our data helped inform the legislature that's going through. The other thing is we can look for creative ways to bring this testing to communities. We are in the process of taking the mobile COVID vans and repurposing them to do lead testing. We can look at maybe finding funding for FQHCs to get mobile units so they can bring services to people who can't make it to the centers, who can, they can cover weekend events or go to people's houses, offer, preventive care, offer vaccines, offer lead testing and things along those lines. So, I think a lot is going to have to come from the local communities as well as from local governments and state governments in the next few years, and being creative and finding, if not federal grants, and foundations that are like-minded and who will support this work.
Thank you so much, Eric. Appreciate that. And we have a few minutes. I think some of the other questions we've had are related to code services and inspection resources at the local level for a lot of municipalities. And, we're talking about, geographies outside of the state of New Jersey. So just related to that, I wanted to highlight that one of the reasons we wanted to lift up the work happening in New Jersey today are a lot about the, obviously the research happening and related services around maternal and infant health. But the state of New Jersey has also recently, within the last few years, adopted a state policy for all municipalities to implement a rental inspection program for pre-1978 housing. So that's another example of a statewide model from happening in New Jersey that we wanted to lift up. And in our follow-up to the email, we will share links to information about all of these things. So one more question for Alex, because you mentioned the 1115 waiver. Is there a kind of publicly facing resource that captures some of the program design that you're thinking about, or a resource related to Medicaid waivers that you think would be helpful for our audience?
That's a good question. I'd be happy to go back to the team and see if we do have something publicly available. So just for full transparency, we have approval from the state, but not from the federal Medicaid office at this point. Their 90-day mandatory response day came on like day 5 of the shutdown, I think. So like,
great.
We're waiting. So yeah, so we are still waiting for final approval. But yeah, I'd be happy to go back to the team if we have something public facing. We'd be happy to share that. Yeah.
Thank you for that. So another question from the audience that I think is really wonderful, and any of our physicians who are on, we're welcome your thoughts on this and how you're working with teams to provide services for patients. From Kelly Dodd, who asked, do physicians feel that they have time to help patients find resources for lead exposure and provide outreach and education for the patients? So if you wouldn't mind talking a little bit more how you're providing that within your organizations.
So I guess if you want a one-word answer, I would say no. We all feel like we don't, there's a 15-minute visit. I don't have enough time to talk about all of the things that I would like to talk to patients about. But, the framework is, as Eric alluded to in the slide, we're testing for all these other things and, the prevalence, right? And so, thank God we have such an amazing team because we really lean heavily on our nursing staff and our nutritionists, who they are the ones who provide a lot of the education. And when we get a positive screen, we have the patient meet with the nutritionist. But, I do think it's really important for the physician to stay engaged because, as Eric said, it's about the messenger. And so, obviously, when I tell the patient, hey, this is really important, it means, we still are trusted messengers, particularly for those patients who are coming to see us, right? The ones who are coming in are engaged in the healthcare system. So they still do believe us. They still do take our advice. So, but it is definitely a team effort.
From the pediatric point of view, we're fortunate to have a team of not just pediatricians, the advanced nurse practitioners, the general pediatricians in the outpatient clinic, the WIC team. So when you put all of those teams together, I feel that we're doing better. Could we do more? Definitely, yes. The other side of it, though, is because we're in Newark, and Newark Department of Health has a rich history of education and funding, not just for lead testing, but that home abatement program. I think it gives us a lot more credibility. But should we have more time to do it? I hope we can.
Great, thank you. So I think it looks like we are close to time. We are going to wrap up here. I want to thank all of our panelists for taking the time to join us, for all of our attendees for recognizing Lead Poisoning Prevention Week, and thank you all for the work that you're doing to address environmental health needs in communities where you're working. If you have other follow-up questions, please reply to our email that we'll send out with these follow-up resources. Natasha, any other closing words or resources you want to highlight?
No, just thank you to our speakers and to everyone who attended.
All right, and I hope everyone has a wonderful afternoon. Thank you and take care. Bye-bye.
Thanks.